So those were the bad old days. Now the disease hasn't changed at all, but it's the treatment that's changed. And one of the exciting parts of working in the HIV area is actually seeing the speed at which treatment has become acceptable, improved, constantly improved, and is now to the point where there's very few side effects. The downside of treatment are very minimal, and almost everyone can actually get on a combination that they will take and can stay on and will control their virus. So it means those bad old days of having a ward full of people dying of opportunistic infections is not happening anymore. It did take an awful long time for us to work out that a single antiviral was not sufficient to control the HIV, and you needed, maybe two. And then that worked better than one, but it was still only delayed the whole disease process. And it was only finally in 1996 that the thought that maybe 3 drugs might work was actually proven to be effective. So I actually sort of see AIDS as, well, the HIV era that we're living through having sort of 3 parts. The first part was the AIDS epidemic, where there was no treatment, lots of opportunistic infections, lots of fear, people dying, lots of stigma and discrimination against anyone who had HIV. Then we had the era of the antivirals, where every conference there was an update on what was the better treatment, what was new, how to use these drugs, and that was adopted really quickly in practice following those meetings. And then finally we're now in the era of aging, where what we have is a large number of people who have been infected with HIV but it's suppressed. And either because of their early damage done by the virus before they started treatment, to some degree the medications that they had been on, and also the lifestyle factors that they may have had, have meant that they seem to be getting older a bit faster than you'd expect in the general population. Now, it's still debatable as to, is it the drugs that have done that? My belief is not necessarily. They have accelerated some parts of the aging process, particularly the thickening up of arteries caused by high lipids is definitely related to the protease inhibitor group of medications that we fortunately don't have to use as much. There have been the non-nucleoside group of drugs that impair to some degree the function of mitochondria in some cells, and that means that those cells don't burn oxygen as efficiently. They don't make energy as well as they should, because the drugs are blocking the ability of those cells to make new oxygen-burning batteries or mitochondria. Now, depending on how the drugs are concentrated in different cell types, that has led to fat cells being affected, and the phenomena of lipodystrophy has stemmed from predominantly stabilidyl D4T use, which was toxic to those cells. Builds up of lactic acid were happening with some of the medications as well. We're seeing damage to nerve fibers because the myelin sheaths weren't being regenerated, and you'd be getting peripheral neuropathy as a complication, which is a poor functioning of the long nerve fibers. So usually patients complain of a burning sensation in their hands and feet because the signals from the pain sensors there are traveling the furthest back to the brain. So the patchy disturbances in the insulation coating of those nerve fibers mean that you're getting white static noise back to the brain that's interpreted as pain. So many of the patients who are on the older treatment, that's been a problem. However, those are really only a few of the issues you get with the medication. I mean, certainly some of the more recently used ones like tenofovir have caused problems in some parts of the kidney, a very insidious and gradual problem where you see really accelerated aging of part of the kidney. So the kidney is functioning like it's 5 or 10 years older than it should be. Now, one of the consequences of that is people would lose bone density, calcium loss, and so that they'll be at risk for fractures earlier than you would expect otherwise.
Sure.
So to some degree you'd find that in most patients this isn't a problem, but then on the background of that, HIV itself is an inflammatory disease. The immune system is constantly in a hyperactive state trying to fight it. It's producing free radicals that are also accelerating aging. So you'll see that aging effect in the cardiovascular system, you'll see it on the brain, you'll see that generally the longer someone's had uncontrolled HIV, the faster their body is aging to try and fight that. Now that is all made worse if they are engaging in other behaviours or lifestyles that are also associated with accelerated aging. So smoking obviously is one of the classic ones. Injecting drug use will stimulate its own set of problems. High alcohol use. These are all things that you see as a layer of extra complexity on the aging process. And when your organs are young and fit, your body can cope with quite a lot of insult. As it gets older, it loses that capacity. So while you could say that the drugs or HIV itself may not be clearly associated with accelerated aging, there are layering of complexities that mean that people have problems earlier than you'd expect them to. So the heart disease is happening 5 to 10 years earlier than you'd expect. We're starting to see, and it's a potential worry on the horizon, the dementias and neurological aging seems to be coming on earlier as well. Now, how much of that is driven by people's previous lifestyle conditions, their smoking, their scarred up arteries, is still unclear. How much was because of their HIV is still unclear, but the reality is that we're starting to see those.
Can I ask, what lessons do you think have been learned from HIV care that have been applied to a wider clinical practice?
Not enough lessons. I really think that there are many areas of HIV which could be applied to other areas of medicine, particularly the involvement of the community in deciding their own care, in relating to the medical care providers. I think that the community should be more active in enlisting the support of governments. And in the HIV epidemic, the community was able to do that. The community was instrumental in bringing together government, doctors, healthcare workers and themselves to decide what was the best way of approaching this disease. And unfortunately, that doesn't really happen in other conditions, in neurological conditions, in Alzheimer's, in dementia, in Parkinson's, even in asthma, in many, many conditions, diabetes, heart disease. There are groups, non-government organisations, but they don't seem to have the same level of proactive involvement with governments and with doctors in deciding how their care should be managed.
Lessons learned from HIV care that have been applied to wider health policy and clinical practice.
I think we've learned a lot from HIV, and it has changed the face of healthcare significantly for everybody. The most obvious one is infection control. We didn't have guidelines like universal precautions or standard precautions before. There was some stuff on body substance isolation, but it wasn't the same as saying, look, you treat everybody as if they're infected. So that's completely changed the way that we've done infection control since the 80s. So that includes treating everybody as if they're positive, but also being really careful about sharps and having specific guidelines for sharps, having safety engineered medical devices. That's all really come about because of HIV. Sorry, my voice. So I think that's a huge change. But also other things like we're really good on confidentiality now, which we really weren't before. And confidentiality was a massive issue for people with HIV in the early days. So I think that's led to good policies across the board on confidentiality in health, confidentiality of medical records, which was always there but was never really adhered to, and the guidelines are much better now. The other thing it's led to is things like recognising non-traditional relationships, so accepting that your next of kin might be your male partner, male from a man might be your male partner. Looking at accepting. Sorry, that's gone over my head. I had something else about that. Good. I think also the whole issue of men's health is, while that's been a parallel thing, I think that's really come up as an issue to be aware of too, that men have unique health problems as well, was the focus was so much on women's health before, and I'm sure that's part of just looking at of gay men engaging much more with the health system than they would have done before. And it also relates to what I was talking about before, that marginalised groups are somehow engaged in the health system. For instance, doing things like needle exchange has meant that injection drug users are now engaging with health systems where they would never have done before, and hopefully a little more trusting, but you can also then steer people into other services such as prevention and treatment services, which they wouldn't have had access to before because they would have steered well clear of the authorities.
I think with that question, I'd like to focus on my role as a clinician looking after people living with HIV for 30 years. And I think that one of the biggest changes in medical practice that HIV has commenced is to change the relationship between the patient and the doctor. That patients were very much empowered to make decisions about themselves. They were dying, they had to make decisions about their future, but also about what drugs they might choose to take into their body. And so there has been a much more strengthening of the partnership between the doctor and the patient. And that, I think, has changed some aspects of medical practice. As time has gone on, it's become a chronic manageable condition. And so how to provide best care in an outpatient clinic or in general practice, 50% of people living with HIV are treated in general practice, in private practice. And so that has also caused changes in how care is delivered for a chronic medical condition. So they were significant in their impact.
Well, I think one of the best lessons that came were a good collaboration between healthcare providers and the clients, and involving clients in their management and discussing things with them, and organising treatments and interventions with the person together with them to manage their health care, because it's an ongoing lifetime treatment. Certainly at this point it is, and it has been from the beginning. Whether that changes in the future is unpredictable, but that's because it's a lifelong, constant collaboration between doctors and other healthcare professionals and clients. I think that's the important thing that we can learn is involving clients in their management and discussing things with them and having them involved, which I think has always been an important part of all health professions, but I think that's been reinforced more and more and more. I think obviously research is an important part of all healthcare, but the importance of research in HIV and the rapid research and the rapid changes that have happened, and the involvement, obviously clients have to be involved in that and agree to participate in research. That's been an important lesson, but also a confirmation of things that we already knew. And I think we working in HIV has also confirmed that, you know, we have to sit back and listen to patients very carefully about the impact that the disease, the illness that they have on their life, the treatments that they have on their life, the expectations that we have of coming to services, and you know, they're all important things. And patient engagement, which I think is a big thing in healthcare now, but I think the importance of that has been reinforced by experiences in HIV.
So when HIV was first on the scene, or AIDS was first on the scene, it fitted the traditional medical model very nicely. You had an acute infection, you'd be admitted to hospital, you got intensive therapies, and then you were discharged back to the community. What's become clear is that that's not good enough in a condition that is lifelong, and even though you can stop the complications, and even though you can suppress the virus, it's a lifelong condition. And you have to maintain an engagement with the patient for the rest of their life. So for many patients, I've been saying to them, you and I are going to be having conversations till one of us dies. And we're going to keep seeing each other until one of us falls off the perch. So it means you're actually trying to look at that long-term picture. You don't have to fix every problem at that visit. You have to try and work out what's going on with people. You have to try and get them to see where they need to change, but it's not as though you have to cover everything on your list straight away and tick all those boxes. You're going to keep engaging with that person hopefully for a long time, and as long as you keep on at things, you'll find that eventually they'll stop smoking, eventually they'll lose weight, eventually they'll get their blood pressure under control, for most of them. But it's also how it relates to the rest of the medical healthcare system. The whole function of treating HIV today is to keep people healthy and out of the hospital system. So anyone who ends up in hospital is a failure on our part. That should not happen. And that's where you need to have engagement with all the other services, the psychologists, the dietitians, to try and actually maximise these outcomes for people.